Good afternoon to all. Today I'll be discussing about the molecule aripiprazole. So we all know about the typical antipsychotics, atypical, that is our first generation, and the second generation. Arip is a special in its own way as it is a third generation molecule which has a dopamine partial agonist activity. It also has partial agonism on D2, D3, 5-HT1A and antagonism on 5-HT2A, 2C and 7 along with antagonism in H1R, M1R and alpha 1R. To see in detail about the mechanism of action, aripiprazole is a partial D2 agonist. Aripiprazole has been shown to exert greater agonist activity at presynaptic D2 autoreceptor than at postsynaptic D2 receptors. Partial agonist is a medication that binds to the dopamine receptor but possesses less intrinsic activity than the endogenous full agonist dopamine. That is, qualitatively acts like dopamine but quantitatively produce a response that is smaller than that produced by the dopamine. Depending on the dopamine level, it can act as either a functional antagonist or agonist, which provides benefit in treating schizophrenia. So what is a functional antagonist? It is in the presence of excess dopamine transmission, it can reduce this transmission to lower levels corresponding to its intrinsic activity, and functional agonist means in the presence of low dopamine level, it can increase dopamine neurotransmission again to the level to its intrinsic activity. Aripiprazole is pharmacologically different to other oral antipsychotic, atypical antipsychotics, in that it reduces dopaminergic neurotransmitter through partial agonism of D2 receptor that are mainly in the mesolimbic and mesocortical pathway. This unique pharmacological profile has led to it being considered a third generation antipsychotic because aripiprazole is characterized by its stabilizing effect of dopamine neurotransmitter, and it is also described as dopamine system stabilizer, that is DSS. Commonly, aripiprazole is prescribed in schizophrenia, acutely in mania, in BPAD, and also in maintenance of schizophrenia, in maintenance or in mania episode, and in maintenance of BPAD, in depression as well as BPAD depressive episode. Other disorder where it is also prescribed are Tourette disorder, behavioral disturbances in dementia, children and adolescent, and also in autism related disorders, irritability. Now we'll see statistically what the researchers has been told about aripiprazole in schizophrenia. The first research will discuss is comparison of efficacy and acceptability of aripiprazole with second generation antipsychotic. This is a network meta-analysis. Outcome has measured the efficacy and acceptability. There were 33 trials comprising of 10,602 participants. Regarding efficacy, response rate indicates that all antipsychotics except for deprasidone were more efficacious than placebo. In remission, cariprazine was not effective. For acceptability, quetiapine, brexpiprazole and cariprazine were worse than placebo. In tolerability, only olanzapine and risperidone showed no significant difference compared with placebo. The administration of adjunctive antipsychotic is associated with high effectiveness and low acceptability. Risperidone and aripiprazole are more efficacious and accepted than other atypical antipsychotic. Aripiprazole versus placebo, improvement of negative symptom. In this, we'll be discussing about 2 meta-analysis and 6 RCTs were included. In meta-analysis, they have included diagnosis of schizophrenia as well as schizoaffective, and the drug they were using were aripiprazole. And in other 6 RCTs, the diagnosis were mostly of schizophrenic patients, and the comparative group for all the studies were placebo. The outcome of all these studies showed a significant improvement in negative symptom in patients treated with aripiprazole as compared to placebo. Uh, this is a systemic review and a network meta-analysis, and a meta-analysis with post-hoc analysis. In this, the drug used in the first analysis was second generation antipsychotic, also aripiprazole, and compared with the first generation antipsychotic. In diagnosis, they kept the patient with schizophrenia, schizoaffective, and different delusional disorder. The meta-analysis and the post-hoc analysis, the comparative group was with amisulpride, and the drug of the cases were of aripiprazole. And the scale used for assessment were PANS in both the study. The result was that some studies found a superiority of aripiprazole in treatment of negative symptom as compared to haloperidol, lurasidone, quetiapine, cariprazine, and amisulpride, while one study not find aripiprazole to be superior to first generation antipsychotic. Aripiprazole as augmentation treatment, improvement of negative symptom. In this, the first study, the drugs were clozapine with first generation antipsychotic, clozapine with second generation antipsychotic, first generation and second generation augmentation, second generation plus second generation, and in the comparative group, augmentation with placebo or continuation with the antipsychotic monotherapy. Diagnosis was schizophrenia and schizoaffective. Assessment was done on PANS, negative symptom, and SANS. The second meta-analysis augmented with aripiprazole, and in comparative group augmentation with placebo or the antipsychotic monotherapy. Patient included were of schizophrenia and schizoaffective. Assessment was done on negative PANS. The other three studies, they have taken only schizophrenia as the diagnosis, and the drug used in the first was risperidone augmentation with aripiprazole, second study clozapine augmented with aripiprazole, and the third study also augmented aripiprazole with clozapine. The result came out to be, compared to the placebo augmentation arm, addition of aripiprazole to another antipsychotic including clozapine showed greater improvement in negative symptom. Aripiprazole and other antipsychotic drug for dual diagnosis. Dual diagnosis refers to the combination of substance use disorder and mental disorder that occur in the same patient simultaneously. Analysis of 41 articles was conducted. Most patients were males and were affected by schizophrenia with cannabis, the most abused substance, followed by alcohol. Aripiprazole was the most used drug either orally or by long-acting formulation, followed by risperidone with oral and long-acting formulation, clozapine, olanzapine, and quetiapine to be followed. The finding highlights the use of second-generation antipsychotic for treatment of psychotic symptoms in comorbidity with the substance use. Aripiprazole in management of schizophrenia in adults. 62 psychiatrists participated in the first round, 33 in the second round. Consensus was obtained from 11 out of 41 items in the first round and for 9 out of 11 items in the second round. Aripiprazole can be used as maintenance treatment for pregnant women in relevant to preserve cognitive function, can be considered an option in patients with comorbid addictive disorder or with persistent negative symptom. In summary, of schizophrenia, up to 60% of patients may have prominent clinical relevant negative symptom that require treatment. Clinical evidence shows a significant improvement in negative symptom in patients treated with aripiprazole as compared to placebo. Some studies found a superiority of aripiprazole in treatment of negative symptom as compared to haloperidol, lurasidone, quetiapine, cariprazine, and amisulpride, while one study was not find aripiprazole to be superior to first generation. Compared to placebo augmenting arm, addition to the aripiprazole to another antipsychotic including clozapine showed greater improvement in negative symptom. Early treatment of psychosis, add-on therapy with aripiprazole seem useful and viable intervention to reduce the severity of unspecified negative symptoms. Coming to major depression, the effect of aripiprazole in depression is through the partial agonism of 5-HT1A and blockage of 5-HT2C, 2A and 7. This is how it works in depression. So coming to the studies that had been conducted, efficacy of aripiprazole as adjunctive therapy in major depressive disorder with somatic symptoms. This randomized double-blind placebo-controlled study with clinical and electroencephalography evidence, participants who has been on stable dose of antidepressant for at least 1 month were randomly assigned to receive a 8-week adjunctive treatment with either aripiprazole or placebo. 41 patients with somatic symptom completed the study. Initial dose of aripiprazole was 2 mg per day, later adjusted to 1 to 10 mg per day. Clinical outcome in aripiprazole group showed a significant improvement in symptom checklist 90 revised somatization score compared to the placebo group. In EEG outcome compared to the control, the aripiprazole group showed a greater decrease in total alpha power. Change in frontal alpha power were positively correlated with changes in SCL90 RSOM score. Aripiprazole adjunctive to antidepressant in patients with major depressive disorder and somatic symptom improved somatic symptom severity without significant safety concern. This improvement correlated with a decrease in total and frontal alpha power. Aripiprazole versus quetiapine as augmenting agent in treatment-resistant depression. Head-to-head randomized control trial was done. Total of 50 patients with treatment-resistant depression were enrolled. Participants were assigned randomly in double-blind trial to receive aripiprazole 10 mg per day or quetiapine 300 mg per day in addition to their standard adjunctive treatment therapy for 12 weeks. Significant decrease in MADRS score was observed with aripiprazole group than quetiapine group. The clinical global impression scale score in aripiprazole group also exhibits significant improvement compared with the quetiapine group. The adverse effect was observed in 11% of patients with more evidence, with more incidence in quetiapine group. The incidence of acute effective results in the discontinuation of therapy were found low in both groups. Now coming to the bipolar disorder, there is only one study that I'll be discussing, that is psychopharmacological treatment algorithm of manic or mixed and depressive episode in pediatric bipolar disorder. In 2005, AACAP published algorithm to guide pharmacological treatment of manic or mixed episode associated with pediatric bipolar disorder. At that time, lithium was the only FDA-approved treatment for pediatric bipolar, manic and mixed episode. Since the publication of the AACAP algorithm in 2005, multiple RCTs has been conducted in pediatric bipolar disorder, leading to FDA approval of 5 medications that were aripiprazole, asenapine, olanzapine, quetiapine and risdon for the treatment of manic and mixed episode, and 2 medications for depressed episode, that was lurasidone and olanzapine plus fluoxetine combination. Divalproex sodium and oxcarbazepine were studied in pediatric RCTs and failed to separate from placebo. Recent studies on aripiprazole has shown that long-term improvement and safety of aripiprazole for irritability and adaptive function in Asian children and adolescents with autistic disorder. In this, this study was done over 52 weeks, multinational, multi-centered, open-level study. The dose was flexible. It was between 2 to 15 mg per day, in which the patient with autistic disorder who had completed an anecdote of 12 weeks open level study. The efficacy showed that during the 52-week treatment, all the effectiveness variables including ABC, CGI, CYB box, VABS and PSI SF scores showed improvement. Safety proportion of patients who experience any treatment emergent adverse event was 58.62%. Most common adverse events was nasopharyngitis. Adverse effect with more than 10% incidence were weight increase. Incidence of serious adverse events was 5.17%, which were epiphyllosis, seizures, and suicide attempts. But these were not adverse reaction. But there were no acute adverse reaction. There were no clinically significant changes found in the evaluation of EPSCs. Aripiprazole showed improvement for behavioral problem and adaptive functioning and was well tolerated in patients with autistic disorder until near a year after drug use. Efficacy of combination therapy for difficulties waking up in school attending student. To date, no sleep medication based treatment for wake up difficulties in non-school attending students have been established. This study assessed the combined effect of sleep hygiene guidance, low dose aripiprazole administration, that is 3 mg per day, and blue light exposure on wake up difficulties in 21 non-school attending teenager patients. The average subjective total sleep time calculated from sleep diaries before treatment in the patient was 10.3 hours, significantly decreased by 9.5 hours after treatment. The therapy improved wake-up difficulty by 85.7%, improved in school non-attendance by 66.7%. The self-rating depression scale and mental competence summary of the 36 items short from health survey significantly improved after treatment. The aripiprazole combination therapy was effective in improving wake-up difficulties and mental quality of life in non-school attending teenager students. Efficacy and safety of aripiprazole in borderline personality disorder. Study objective to investigate the efficacy and safety of aripiprazole in patients with borderline personality disorder. Two published randomized clinical trial with 76 patients with borderline personality disorder, whereas 38 were assigned for aripiprazole, 12 for olanzapine, and 26 for placebo groups were included. Most patients were female with age ranging from 22.1 to 28.14 years. Aripiprazole has been proven to reduce anxiety, depression, anger, hostility, clinical severity, and obsessive compulsive behavior, insecurity, melancholy, aggressiveness, phobic anxiety, paranoid thinking, psychotism, and somatization. The adverse effects were headache, insomnia, restlessness, tremors, and akathisia. Aripiprazole has been demonstrated encouraging outcome in treatment of patients with bipolar borderline personality disorder. The potential role of aripiprazole augmentation for major depression disorder with anxious distress in naturalistic treatment setting. The objective of this study was try to observe clinical benefit of aripiprazole augmentation treatment for major depressive disorder with anxious distress in routine practice. Changes in endpoint during the study, all score are significantly improved. Primary endpoint HAM was 5.73. Secondary endpoints were Hamilton rating score to come to less than 3.4. CGI also reduced. No significant adverse events were observed. This study has shown additional benefit of aripiprazole treatment for major depressive disorder with anxious distress patient in routine practice. Efficacy and safety of aripiprazole in treatment of delirium. Systemic review of the database was conducted. Results were limited to case report, clinical trials, and randomized controlled trials. The results suggested that aripiprazole can be used in treatment of delirium symptom. There is evidence that aripiprazole has efficacy comparable to haloperidol and other second generation antipsychotic. Aripiprazole can be a better option in particular group of patients due to its safer cardiological and metabolic profile and better tolerance to the treatment. Now coming to the safety profile of aripiprazole, according to the study, antipsychotic safety in liver disease, 21 papers were included in this systemic review. Evidence shows antipsychotic induced liver dysfunction is uncommon to rare in aripiprazole. Along with aripiprazole, paliperidone, lurasidone, loxapine has reported lower chances of liver disease. Comparative effect of 18 antipsychotic on metabolic function. It was a meta-analysis of 100 randomized control trial, including 25,952 patients. Median treatment duration was 6 weeks. Uh, as per this meta-analysis, aripiprazole was safest after haloperidol and ziprasidone for metabolic syndrome. In this, they have seen the body mass index, glucose level, LDL cholesterol, total cholesterol, HDL cholesterol, and triglyceride. Aripiprazole was the only antipsychotic to show across all parameters either no evidence of change or improvement in metabolic parameter level compared with placebo, considered the safest option in those at an increased risk of developing metabolic complication. Um, to see the prolactin raising and prolactin sparing antipsychotic drug and the risk of fracture and fragility fracture, meta-analysis of 36 observational study conducted is mostly elderly sample. Antipsychotic exposure was associated with increased risk of hip fracture, increased risk of any other fracture. Observational study, fragility fracture in patients with schizophrenia were associated with higher daily dose, higher cumulative dose, longer duration of treatment, and prolactin raising rather than prolactin sparing antipsychotic. In patients receiving prolactin raising antipsychotic, the concurrent use of aripiprazole appeared protective. So summarize, newer evidence is assuring the efficacy and safety of aripiprazole in management of schizophrenia and also other diseases that has been discussed. Also, evidence are available for various other psychiatric disorders. Thank you.